Okay. So, good morning, everybody. Hopefully, everybody's awake after the long weekend. As you all know, every year, third week of April, we celebrate as a National Medical Laboratory Technology Week, and we all look forward to contribute in some way. I have a great opportunity to introduce today Melanie Peralta. She's an MLT and team lead of LMP Pathology Research Program. She grew up in Winnipeg, Manitoba, and is a graduate of MedLab program from Red River College in 1998. So Melanie moved to Toronto to start her career in histology in 2002 and was hired in Pathology Research Program at UHN as an advocate and supporter of academic practice in lab medicine. Melanie also had a part-time contract from 2004 to 2010 as a histology instructor for Michener's Foreign Client Bridging Program. In 2010, she assumed her current role as a PRP team lead and is now a driving force behind the research services offered by LMP. Melanie is taking us into a deep dive of the PRP, who they are, what they do, and the services provided by PRP. Melanie's talk will cover how important and integral the department is to research at UHN. So everybody, welcome Melanie.
Thank you, Aparna. Welcome everyone this morning. Hopefully you had their coffee like I did. My nerves are like going nuts right now. Haven't done this in a very, very long time. So, as you know, we're going to be talking about PRP, which stands for Pathology Research Program within the LMP here at UHN. Pathology Research Program actually started off quite a while ago. So what we're going to talk about is who we are, why we are part of LMP and UHN, and what services do we really offer. I think most of you guys don't really know what we do. We exist, but I don't think much people know what we really do. So this is going to be an opportunity for you guys to see what type of research we've been diving into and what type of research we're working with. So here we go. All right, so around 1998, the lab was called actually Clinical Research Program. At that time, it was only funded by a small group of investigators to support a single lab. So basically, it's like a bunch of pathologists or a bunch of researchers that gathered their grant money and said, hey, let's start a lab up. And it's just for them to use. So it's just for the group to use. In 2006, PRP Pathology Research Program was created and departmentally supported by LMP. So basically, LMP took over and said, this is going to become part of our department. So currently, the lab is staffed with a total of 6 employees. At one point, I think we had 8 back in, I would say, around 2000, 2002. But we've recently had to go a little bit smaller because a lot of people have left to move on to do other things. And we found with the smaller group, it seems to be working out quite well. So now we have 5 MLTs and 1 technician. And our medical director is Dr. Vanderquast, which I'm pretty sure majority of you guys are familiar with. And of course, our manager, Rose Belcastro. So what we are is we are an independent lab that provides a fee for service. So basically, someone comes in, pays us to do the work, and then we give it back to them. So we work mostly with grant funds, pharmaceutical clinical trials, private labs, academic institutions like U of T. Recently, I've worked with, or not myself, but the lab, with McGill, McMaster, also from U of BC. We've got specimens from them asking us to do work for them. And then, of course, patients. Patients, I know, is a rare one, but sometimes patients need histological work done that they need to bring with them to another country. And it's not necessarily diagnostic, it might be for other reasons. So we do also work for patients as well. Okay, so why are we part of LMP? Well, there is a vast amount of research being done at UHN. So as you know, UHN is one of the largest hospitals in the world that does research. We're really known for it. We've got at least about 6 institutions that are within UHN. One of them is Kremble, McEwen Stem Cell, PMCR, which is also called Princess Margaret Cancer Research, TECNA, TGH, and KITE. KITE is actually part of the Rehab Institute, and they do a lot of, lab work and research on joints, rehab with muscle, skeletal, so they do a lot of that. So we're quite large in the research realm. And the areas that you're going to cover in research, you've got cancer, cardiology, transplant, immunology, infectious diseases, musculoskeletal, like I mentioned, and neuro, which is done at the Kremble, actually. That's another big one. So we're quite large. So as you know as well, TGH recently was recognized amongst the top 10 in the world of hospitals. TGH was cited for leading in the transplant research realm, and this is why we're on the map. So now UHN is actually even more magnified than it was before. So research now is getting pretty big. It's getting pretty busy. So we're seeing a large amount of work coming in. We've actually seen the work double in the last 2 years, which we have never seen before. Normally it's nice and steady, regular things, but lately we're getting more and more special needs, special requests. So this is why it's important for LMP to be part of this. This actually puts us on the map, puts pathology on the map and LMP on the map. So we're actually a driving force in moving with innovation and moving with the research rather than staying stagnant. So this is a good thing. So together, of course, we're going to collaborate. We're going to move. We're going to be together as one, as a lab functioning for research and for diagnostic work. So here's the services we offer. So we basically do histological stuff, histology. So most of you familiar with histology in here? Okay. So we do the basics. We do gross, tissue processing, embedding, sectioning, staining, i.e. hematoxin and eosin stains, and special stains, and as well as frozen sectioning. The special stains actually is not done physically in our lab. It's actually done by the diagnostic clinical pathology lab or histology lab, because they have the bigger amount of slides that they can handle, so they have more solutions that they can use, and they're actually the experts at it. So I have to give credit to the histology lab for doing our slides, especially our trichromes, because we do a lot of those. We also do specialized histology. So specialized histology is whole mounts. So whole mounts are actually whole tissues. So just let's give you an example, a prostate, or what they call a radical prostatectomy. So it's a cancer, it's a prostate about the size of a golf ball. So what they'll do is we'll actually slice them into about 3 millimeter thick sections with a deli slicer. Do you guys know what a deli slicer is? I know, it sounds gross. You use a deli slicer to cut them really thin. They'll be fixed, and then we'll process them. And then we mount them whole. So these are actually going to go on 2x3 slides. They're very, very big slides. And then we stain them for H&E, IHC, or even a regular trichrome. So these are going to get done the regular way you do histology, but just huge, huge samples. So we do a lot of that now. It's actually gone up again, double since in the last 2 years for whole mounts. Agar cell pellets, if you are in cytology, this might sound a little familiar to you. Basically what you're doing is you're taking cells that's in a fluid or in a medium, you spin them down, and then you get this button at the bottom which is just full of cells. You take that, pipette the supernatant off, and put the agar in and let it solidify. So once it's solidified, you can take it out and the button goes along with the agar, and then we're able to do regular histology on that. We're able to process it, cut it, stain it, do IHC on it. But it's just all cells with no connective tissue. So that's what an agar pellet is. They also use histogel just like cytology. The other one are cell cultures. So cell cultures is actually not done as much nowadays, but basically what they're doing with this one is they're grown on a plastic plate or a petri dish. They're one layer or maybe two layers of cells on a petri dish. We'd actually fix that like a frozen using either PFA, acetone, or methanol. And then from there, we would stain them. We would stain them directly onto the petri dish and then put an actual crystal mount, which is just an aqueous mountant, like a liquid cover slip, and we'll be able to view them that way. And then our biggest, I'm skipping, the RNA DNase free sectioning. This is something that's done for molecular. If you're in histology, you probably do this from time to time. But we usually cut sections at a much thicker thickness, at about 7 to 10 microns thick. And we do paraffin scrolls. Does anyone know what paraffin scrolls are or might have an idea? Paraffin scrolls are exactly what it is. You basically scroll it, and it's a little scroll, and you put it in a tube. And then from there, they'll do PCR, do what they need to do with that. We put it into an Eppendorf tube. The other one is 1 millimeter core punches or 0.5 millimeter core punches. Some of them go up to 2 or even 4. We do 1, and it's basically we just core it right out of the block using a corer, and straight to molecular it goes to do what they need to do with it. So we're quite specialized with this. We actually use RNA DNA-free water in order to section. We also use RNase away to clean the whole area before we even cut sections. So we actually prep everything before we even start cutting or even working with the sample. Immunohistochemistry is one of the bigger ones. We've been around for a long time. So immunohistochemistry is very similar to the way the clinical lab does it, except on a manual level, meaning nothing is automated. Everything is done by hand. So that's going to be a fun one when we talk about that. And the new one, the new addition, this has come into the realm maybe in the last 3 years. It's called RNAscope. So if you are in cytogenetics or what's the other one? I forget. Cytogenetics? I think so. That does ish or fish. This is very similar to it. The only difference is this is all done within a protocol that's provided by exactly that, which is advanced cell diagnostic. It's an actual protocol that they've created. And we've been able to mimic this protocol and actually reproduce it. So now it's becoming big. And you can actually run this on a automated platform in Immuno. It's not going to be specialized anymore where it needs to go somewhere special. I don't know if it's as good as it can be just yet. I think it's just coming into the realm. So we've worked very closely with Dr. Fisher on this, working on the GATA6, which I'll talk about later on with this. So those are the services we offer. So now we're going to get into the fun stuff. The samples that we get. Everybody asks me, what kind of samples do you get? Well, main thing, human, definitely. We work with a lot of diagnostic samples that are for research, not for diagnostic, but for research. So human is number 1. Next to that, we've got the mouse. Then we've got the rat. We've got ferret, rabbit, yes, dog, I know, that breaks my heart. Monkey, pig, woodchuck. Just an FYI, pig, the pig heart is actually the closest to the human heart. And this is why it's used a lot for heart studies in research. Woodchuck is a new one. We just recently got that. We're still trying to figure out how to test those ones because antibodies don't seem to like woodchuck. It's very finicky. Zebrafish. Is people familiar with aquatic fish? Yeah, zebrafish. So these are really small. The centimeters are right there. They're quite small. These ones were a challenge to work with. So what they did with these zebrafish is they injected it with tumor. They inject it with tumor, it grows very, very quickly, and they're able to treat it within the petri dish. So you don't have to inject anything, you just put all the drug treatments in the water and it does all sorts of things. I know, I was kind of surprised with that myself. I'm like, really, we can do that? Wow, things you learn when you're in research. So that one you'll see actually. Cell lines, that's exactly what we use the agar for. So we do cell lines as well. Xenografts. How many of you have heard about xenografts or know of xenografts? Or is this the first time you're hearing of it? Xenografts Basically, it is exactly what it states there. You're taking human samples or human tumor cells and injecting them directly into the mouse. And the mouse will provide the microvasculature to grow the tumor. This is how they actually test markers or test how quick the tumor is going to grow, how well the type of drug therapy or immune therapy they're using will actually work on these mice. So that's why xenografts, you have to use especially genetically grown mice. These mice are usually what they call SCID or non-SCID, which is basically immune-compromised mice. So they have no immune system. It's completely knocked out. So that's what you need to use in order to do that type of work, xenografts. And usually the basis of research will start actually at that level, which is at xenografts or pure mouse. That's the other ones. And the other one is allografts. Similar, except it's same species. So you're transferring tumor from one mouse to, let's say, a normal mouse, or vice versa. So that's what an allograft is, same species. So you'll see a little of that as well. All right, if you guys just ate, I'm sorry if anything grosses you out. All right, so in PRP, we get requests. The requests we get are not normal. So they're not gonna be like, oh, I'm getting a liver biopsy. I need 5 levels on it, a trichrome H&E, PAS, PASD, silver, and I don't know, maybe 3 immunos. It's not standard at all. We get them on pieces of paper like this, where they draw it out for you. And they tell you, I want this, this, and this. Mind you, half of the researchers we work with are either biophysicists, biomedical engineers, or they're in chemistry. It's like totally not, they have no idea what to do with tissue. So it's like working with a student every single time you get them in. So we actually have to work with them one-on-one in order to understand what they want. So this is actually a rabbit carotid artery. So what they did is an anastomosis. Does anyone know what an anastomosis is? Go ahead, Martin, tell us what it is.
Anastomosis is when you rejoin two tubular structures after a surgery.
That's exactly what they did. So in the graft, so you can see where the graft is, and you can see where the actual distal proximal and the anastomosis is, where they stitched the two together. So they want to see what's going on in there. So they drew me this wonderful diagram telling me, can you do this? And I said, well, yeah, I think we can. Though it took a lot of imagination, especially for the graft, because how are you going to keep them in order and still be able to look at them? And these are small. They're not like human samples, which are quite big, and you can put them in individual cassettes. And they tell you, oh, we want it all in one block. That makes it even more difficult. So I'll show you the next one. There it is. We actually had to use the 4-chamber biopsy cassettes in order to do them, and they wanted a cross-section. So the first two, actually, where it says cross-section, that's actually where the anastomosis is. So this was actually our first run at it, saying, okay, let's try and just do everything in one block and just have them in order and see if that works for them. And then they didn't like it, and they said, no, I think we'd like them separate. So actually, after this, we started doing them separately. So one cross-section per box. And in order to keep them in order, we had to label the sides to know which was 1 all the way to 4. And then you have to put that onto the slide in the same order. So a lot of this is very technical work. It's not something you can rush. It's something that needs to be kind of taken into consideration while you're cutting and while you're grossing and while you're staining. You've got to keep everything together, everything in the same direction, in order for them to know what they're working with and how they're going to work with it. So that's one. My favorite, pig hole mounts. These are the big samples that keep coming in now. One of them, I know, women, sorry, it's a pig nipple. Pig nipple or pig breast. And what they're doing is they're injecting it with biomaterial. And that's what they're interested in, is what's going on with this biomaterial. What is it doing in the actual pig? What immune responses are going on? Is there any scarring? Is there any leakage of this biomaterial? Sometimes these biomaterials are plastic, silicone. Some of them are cell, like grafted cells. So we never really know, because we like to keep things, we don't want to be biased, so we don't want to know what's actually in them. We just need to know, is it affected by xylene? Is it affected by heat? Is it affected by cold? warm. We need to know all these things. So when we meet with a researcher, we need to know all the details as much as possible in order for us to do the work. So this is actually quite big. So you can see the cassette is quite large in comparison to a regular cassette, which is the yellow one. That's a regular cassette that you get in pathology. So these are about 2 by 3 inches in diameter and in size. So the next one, are you guys all familiar with Dr. Laflamme's work? So Dr. Laflamme, he's been working a lot with stem cells. So he's been bringing his pig hearts to us in order for us to cut so that he can see what's going on with them. And as you can see at the bottom, that is the pig heart cut cross-sectionally at about 3 millimeters in depth, so in thickness. And they actually have to see the whole entire picture in order to find out what the stem cells are doing and what's happening to the microenvironment around the stem cell. So that's what we're working with currently. They actually bring a lot of work. They bring about 20 to 30 samples a day, and we can only run about 12 at a time because they're so big and our processor can only hold 150 regular samples. We have to actually only be able to process 12. And the processing of large samples is much different from histology, regular histology. We're actually processing these at about 26 hours. 26 hours to 30, depending on the lipid content that's in the tissue. So everything is about double amount, even the wax. We have to use double the amount, double the size of the actual mold. So those are pig hearts. My favorite, these guys bring things by the hundreds. So we actually work with other institutions. So what I'm talking about is Sick Kids, St. Mike's, Sunnybrook, U of T. We work with a lot of other institutions. And this one is probably our bread and butter. These guys bring it like clockwork, and it's the most simplest thing they want, just an H&E. They want us, but the hard part is the actual spinal cord. So the spinal cord, that spinal cord actually in length is only about 1 centimeter to about 2 centimeters in length. They want us to cut them down to about 2 millimeter sections and embed them cross-sectionally, meaning, yeah, yeah, microscopic. So if you look at the two on the far here, far, I don't know, left, yes, left, my left, and the actual on the right, you can see the tech is actually cut them down on the other side, and we're actually embedding them cross-sectionally into one block, because that's what they've requested. They want everything in one block. So they want 12 pieces in total, if at all possible, along with the brain. And all they're looking for is a tumor. That's all they're looking for. So this is actually quite tedious. We could probably finish one block in about 5 minutes now, which is pretty good, but before it used to take us about 15 to do that. Okay. My favorite, zebrafish. These are actually baby embryonic zebrafish. Not embryonic, they're just babies. They're about a day old. And as you can see, I don't even know if you can see, they're quite small. So, I mean, these are like, some people can't even see it. They have to actually use a magnifying glass in order to see them. So we need to actually process these in a processor and cut them. So that's what I have here for you. We actually get them, we put them on a filter paper, or not filter paper actually, that is lens paper, and we try to make sure we have a number on there. So they usually tell us about how many zebrafish they bring in, so we count and make sure that that's what we actually received. If we lose one, we email them and say, yeah, we can't find another one. They're usually pretty fine with it. And then we embed them into wax. So to get them into the wax, which is there with the metal mold, is quite difficult because they're sticky, and they actually, if they cool, they can get stuck to your forceps. And they're so tiny, it's hard to see them. So when we're working with these, we have to work quite quickly with them. And we always have to have our forceps quite hot. So what we actually developed, I don't know if you want to call it developed, is we actually took a microtome blade. We stick it into the, this is really bad. We stick it into the incinerator, heat it up, and scrape all of it off the paper and put them into the wax. That's the only way it works. There is no other way it would work. And magically, they appear on a slide. We are able to cut them. You can't trim them, so you have to cut them right at face. So as soon as you see one, you cut 10. And then you pick the one with the most fish on it. And that's what we did. And then, of course, right beside it is the H&E. This actually is normal. This is a normal fish. I think in the next slide, there we go. The one at the bottom here that's closed is the one that's mutated. Everything else is normal. And all they're looking at is in that gut. What they're looking for is cell death because they've treated it. So they want to know if there's cell death going on there. So what they're looking for is what they call apoptosis. And usually there's a technique that we use for that, which is in situ end labeling, a molecular technique in a way. And we use it quite often, and it's a homemade actual protocol in PRP. We don't buy the kit. This is actually homemade by us. It was started by he's not a doctor, sorry, Kelvin So. I don't know if some of you guys remember him, but Kelvin was the original supervisor in PRP. He actually developed that protocol. So we still use it to this day. So that's zebrafish. Mouse kidney allograft. So I have the 3 kidneys. They're, again, tiny, as you can see, comparison to the hand. The allograft is where it's white. So you can see that. And so they want to see what's going on there with the integrity of the actual kidney at the same time. So we actually had to cut this like a book, open it like a book, so on the longitudinal axis, sorry. And therefore, we get to find the grafted cells. And they're looking, again, for certain things, microvasculation, possibly immune responses to it. So that's what that is. Okay, immunohistochemistry. Like I said, we do not have an automated system. This is exactly how we do it. So we would process in a week, we could probably process over 100 slides. The thing is, unlike immunohistochemistry, you can batch them in the clinical. So let's say you've got 20 to 100, estrogen receptor. You've got another 50 progesterone receptor. With us, each tray actually will have 4 to 5 different markers in each tray. It's not the same. So for us, it's even harder because we're not working with one species. Sometimes we're working with 2 or 3. So if you're working with a xenograph, so here's a little education. So you're working with a xenograph. Basically, you've got human cells in a mouse environment. You're going to do CD31. CD31 is a vasculation marker. What would you target? Mouse vasculature or human vasculature? Any guesses? How many of you would say human vasculature? How many of you would say mouse vasculature? It's mouse vasculature because it is the mouse vasculature that's feeding the tumor. So the tumor is not suddenly going to create a vasculature there. It's not suddenly going to have this whole system of endothelial cells. It's going to be fed by the actual mouse environment. So this is where it's very important what type of CD31 you're actually going to use. And it can get quite confusing when you're running 4 or 5 different markers. So our lab developed their own little systems. As you can see, there's like little tags on the lids there. That actually tells us what antibody we're using, in what order they need to be in with the kit, and what time it's going to finish. So we put times in there as well. It's quite a well-invested process. Pretty good. So we're able to do at least 100 in a day, at least. We do work with over 500 different antibodies, some of them brand new, some of them homemade, some of them fluorescents. But there are some that, honestly, we've never worked with, and we don't even know if it's going to work. So it's completely blind. We have no idea, and I love it when the researcher comes to us and says, "Can you get this to work?" Sure. Do you know what it's supposed to stain? No. Oh, okay, great. So we don't even know what pattern we're looking for. they say in some papers it's cytoplasmic. That's how vague it can get. And so this is where you're going to need a pathologist on board in order to help. Because in all honesty, I wouldn't know myself. Pathologist is the only one who's going to be able to look at that and say, oh, it's staining immune cells. Oh, it's staining skeletal. Or it's staining some other cell that in there that's, they didn't even know was going to stain, besides the tumor. So it can get quite interesting and a little frustrating if you don't know what you're working with, if you go in blind. So this is immunohistochemistry for us on a daily basis. This is working with a xenograft, both with cell pellets. So basically there are HeLa cells, they're just tumor cells. And what they did is, Vaccinia is a very special antibody. It actually targets viruses. So what they did is they actually put virus into the infected cell, and this Vaccinia should work, which it did. So that's an immunohistochemical stain. And in the non-infected, it was negative, which is good. That's what we want to see. So now they took it into the mouse, which is the mouse xenograph. And this is where they needed to see, will the tumor stain, will the normal stain? What's going to happen here? So in this case, this was a negative control, so they injected the actual non-infected in there, and they have normal pancreas, and it's negative, which is good. So that means if it is positive, it's only going to stain positive for Vaccinia. So it's specific, which is good. So this one is used in immune therapy recently, Vaccinia. It's using viruses in order to get to the tumor. I don't know if you guys have heard of that one. It's a new one, even for me. So they basically get you sick. If you have a tumor, they're going to get you sick. And this virus is supposed to attack the tumor and reduce it in size and actually help. It's more targeted. I guess that's the theme I'm looking at here. It's a targeted type of therapy. This is still it's in humans already. They're doing this in humans already. But I don't know to what extent yet. So when we started this was about 3 years ago. So it's been moving forward ever since. This is the work that Dr. Fisher's been working on, which is GATA6, which is an IHC. You could do it IHC, but this is where we now incorporated RNAscope. So RNAscope is supposed to be a more sensitive technology in order to find that if it's positive or negative. Because the problem is with the GATA6 IHC, it'll stain normal tissue. So it's positive in stomach, it's positive in normal liver. In tumor, it's also positive. But what happens if you have a loss of it? Is it completely lost? Or is it partially lost? Or is there some there, we just don't see it on an IHC? So RNA-ish, or RNAscope, actually proved that. So they're actually writing papers on this right now. It's called the COMPASS project. And she's actually testing this on actual patient materials right now. So this is actually probably going to go diagnostic I'm going to say maybe in a couple of years or so, depending on what their findings are. But they are expanding this to other tumors now. So this is where the new technology is. And right now, this technology is still fairly new, so we're still testing it on other tumors. And we're still trying to fine-tune the protocol. So the protocol we followed is actually given to us by ACD, but we actually had to tweak it in certain things because you also have to play into account fixation, what type of sample it is. Is it a cell line? Is it pure tissue? Is it, there's other things, cytology specimen. So you can use this on a wide array of things, but each time the treatment's going to be different, the pre-treatment, in order to get the RNAscope to work. So that's GATA6. Okay, that's the end. So I hope you enjoyed it, and I hope that you guys have a better understanding of PRP. If you have any questions, I'm open to them right now, if you like, if there's any at all.
Is the GATA6 stuff the stuff that Sherry was working on with you when they were trying to do the fluorescence and IHC together?
No, that's a different one. One of them was P63, where we're doing 2 different types of P63, and we were doing a dual. I don't recall the GATA6. Maybe GATA3. Was it with Dr. Asa? Oh, P63. Definitely P63. I think they got that one to work, actually. The dual. So they did a dual IHC and FISH, was it? FISH? FISH, yeah. So I did IF, IHC method, or the regular method, immune fluorescence, and then she did another one using FISH, and it worked. I don't know how, but we managed to get it to work. Any other questions?
What do you think like the biggest maybe like challenge or difference from someone moving? Because most of the staff are formerly clinical staff, right? So moving into this kind of research realm, like everything's like set SOPs, and now you're kind of in a more, it sounds like a creative mindset. And what's like the challenge of that transition?
The challenge is, the problem is, when you're coming out of the clinical realm, you are set with your standards, your guidelines, what to do, what not to do. In research, it's kind of like, hey, do everything. We're like, I don't know if that'll work, but it's really that. You really sit there and look at this protocol and go, okay, how are we going to approach this? Because sometimes they can get very technical and they'll say, oh, I only want this proximal side, but the back side of this proximal side. I'm like, okay, you know what? Email's not going to work. I need you to come in. I need you to show me where this is. And sometimes it's easy. It's just, oh, you just want it on the flip side. Great. Sometimes it's like that graft where like, oh, so you needed an order from distal to proximal. Okay. And they're small. Okay. How are we going to deal with this? Zebrafish was another one. Those really, really small ones, we tried different methods. We even tried it in agar and histogel. And that wasn't working out. The only way we could get it to work was with nothing and just filtering it right onto the lens paper. And then picking them up one by one or scraping them right off that in order to embed them and get them as flat as possible to the bottom of that mold. Because if it's not flat, you're not going to get everything on one shot. So we got lucky with that one. But we've got a protocol set for that now, and it works like a charm each time. And the other challenge is they come and go. So basically, you set a protocol, it lasts for 6 months, and then they walk away and say bye-bye and don't come back for another 5 years. And that's challenging because you don't know, do I get rid of this protocol or do I keep it? Or do I archive it? What do I do with this? Some never came back at all, never did it again, and some, it's been repetitive. So zebrafish has been repetitive because it was successful. So usually successful ones, they come back. Any other questions? Okay. Thank you. Thank you guys for coming. I'm finally calm now. Caffeine's left.
Wow, what a great talk. All together, like immunohistochemistry, histology, molecular, cytogenetics, everything in a little place. Very good.
Literally little.
Yeah, literally little. So, thank you so much, Melanie. We have this
Oh,
card for you.
it wasn't enough to be on video. Thank you very much. Thank you.
And everybody, just remember, every day we have tickets for raffle draw, and every session, end of the session, we will draw it. So I'll ask Melanie to draw it for us.
How many am I drawing?
There are 2 prizes.
2?
Yeah. So draw one first.
All right. Don't blame me, okay? I'm not being biased here at all. There.
So I'll read the number. 635881. Uh-oh. So we are keeping it to claim it later on, are we? Yes, yes. Yeah,
We'll
so,
send out anyone who's not here, because I understand like people have to go back to benches at times. I mean, we don't want to reward people who just come and take a ticket and leave, but at the same time, let's assume that this person is here for most of the session, so we'll send out an email.
yeah, so before end of the week, they should claim. And now the other one, second one?
Yeah, second one. I'm getting in trouble twice now. All right. There you go.
Okay, 635873. Hopefully someone here. Yay!
Hey, Lucy! Buddy old pal, my lunch mate. Thank you. Thank you very much. I'll see you guys at lunch.
Yeah, that's right. Yeah, yeah, you got it.
Aw, thank you. Oh, they're e-gifts or no? Oh, just pick it up later. Okay, got it. Don't tell my husband.
Very good.
Really? Oh, my heart rate's still up. See, 120.